We have only 15 minutes left. So, and 84-year-old women presented with 2 days. So we will try to finish, okay? We'll try to finish. We will take a little bit more time, no problem. Then we will reduce time in, we will try to do our TBL fast. So 84-year-old women presented with 2 days history of jaundice. So see the age. Fever and abdominal pain. Fever also and abdominal pain. Physical examination showed scleral icterus and right upper quadrant tenderness without inspiratory arrest at palpation. Absent Murphy sign means when touching at gallbladder, pain is not there. That means more. Laboratory workup revealed leukocyte is this. So this is a higher leukocyte count. And elevated C-reactive protein, cholestasis means bile is obstructed. So bilirubin is 5.4. Okay, total bilirubin. Alkaline phosphatase is this, 893. So gamma GT is also high, 1143. You can see EST alkaline aspartate aminotransferase. You can see 231 here and 178. So it is less than 10 times. Abdominal ultrasound demonstrated scleroatrophic gallbladder with cholelithiasis, and an impacted large gallstone is common in the common bile duct with dilated common and intrahepatic bile ducts. So what is the diagnosis? Be quick to answer, okay? We will have to do other question also. Obstructive jaundice. So what are the supporting factor in diagnosis? We have discussed supporting factor.
Elevated ALT.
Yes.
Elevated GGT.
Elevated, is it supporting factor? Okay, elevated GGT is also a factor. Then you can see these are the factors that based on which we diagnose. One clear diagnosis we can see from ultrasound, cholelithiasis. That is what obstructed jaundice. So you can see here bile is very high. That is actually giving the clue. And this is the alkaline phosphatase is originated from liver. That means if GGTs both are high, this means this is hepatic alkaline phosphatase, and it is more than 3 times. It is more than 300. That means 300. That means this is why this is obstructive jaundice. And then if you see this ALT, AST, this is if you see divided by 50, and this also with 50, okay, it is hardly 5 times. Hardly 5 times. That is why no hepatic jaundice. So hepatic jaundice is, so what is the color of stool? Color and consistency of stool you can see. What is the color of stool? First tell me.
It will be pale.
Color of stool will be pale, yes. And then consistency, it will be clay colored, okay? And what is the consistency of stool? What is the consistency of a stool? The stool will have fat in it because bile is not flowing to. So fatty stool. Remember that, fatty stool. What would be the color and normal component of in abnormal component in the urine? The color of urine is will be dark, and then it comes, there will be bile salt in the urine. So understand this now. So let's talk about this second case. So 16-year-old male came to the office with poor appetite, nausea, vomiting, fever, pain in the upper right part of abdomen, and deep yellow colored urine was there, but stool was colorless, so clay colored stool. On examination, there was mild hepatomegaly, yellowish upper bulbar sclera. On investigation, you have seen high ALT, okay, AST is this, and ALP is this. Total bilirubin is 8 mg per deciliter. Direct bilirubin is 5. So what is the diagnosis?
Hepatic jaundice.
Yes, very clear. So ALT, AST is high. Hepatic jaundice, probably because of infection. Fever is there. Because of infection, hepatic jaundice. So what is the investigation that you will, that suggest this diagnosis, that have suggested this diagnosis? What is the investigation? The investigation you can see here, ALT, AST, and here bilirubin also you can see. Direct bilirubin is, total bilirubin 8. Direct is 5, means indirect is 3. So direct, indirect, both are raised. That is why this is hepatic jaundice. What would be the color and consistency of stool again?
Clay colored.
Yes, clay colored. And then consistency again will be fatty. Fat will be this. Fat will be fatty stool again. So what would be the color and abnormal component in the urine? Color again, dark color, same as obstructive jaundice. You will find bile salt here also. Okay, so case 3. 8-year-old Mediterranean male presents to office with fatigue, headache, lethargy. So fatigue, headache, lethargy, these are presentation of what? Presentation of what? Anemia. So shortness of breathing is also presentation of anemia. Yellowish eye. So this is jaundice. On investigation, the hemoglobin is 9 gram per deciliter. So I told you mild, moderate, and severe. 12 between 14 to 12 you can see mild. Between 12 to 8 it is moderate, and below 8 is severe. So this is moderate anemia. Hinge body in peripheral blood smear, negative Coombs test. Total bilirubin is this. Total bilirubin, direct bilirubin is 0.8, means complete indirect bilirubin is there. So liver enzymes are normal here. So what is the diagnosis here?
Prehepatic.
Is it good? Prehepatic. Prehepatic, hemolytic. Most probably which hemolytic? What is the cause of hemolysis here?
G6PD deficiency.
Body, G6PD. G6PD deficiency. So you can see what are the investigation that suggests the diagnosis? Normal enzyme. And yes?
Also anemia.
Anemia. And indirect bilirubin is very high. Unconjugated bilirubin is very high. 7.4 mg per deciliter. So these are the diagnosis. So what would be the color and consistency of stool here?
Normal to darker.
Yeah, normal to darker. Very good. Normal to darker. What would be the color and abnormal component in the urine? So color will be normal, and component will also be, there will not be bile salt. No bile salt. So we are generally focused on bile salt. That is why no bile salt. Okay. So fourth. So 30-hour-old newborn, full-term vaginal delivery to the healthy 28-year-old mother appears slightly yellow. This baby appears slightly yellow. Okay. There were no complications at delivery. The baby has been feeding well. A bilirubin level returns to 18 mg per deciliter. With direct is only 0.6. So most of them are indirect bilirubin. 17.4 is indirect bilirubin. So parents are now concerned about the baby's discoloration. Which of the following is the next step in the management? So what is the diagnosis? Tell me, what is the diagnosis?
Neonatal jaundice.
Yes. So it is generally physiological jaundice. Can be pathological region, can be there, but this is neonatal jaundice. Is the proper terminology. That's good. Thank you. Neonatal jaundice. Neonatal jaundice has most common physiological jaundice. Okay, there can be pathological as well. So you have to rule out that pathological. We are not going to talk about. So neonatal jaundice is the cause. Okay, then what would be the treatment?
Phototherapy.
Yes, phototherapy is the treatment. And with phototherapy, repeat bilirubin test every 6 hours. So this is the answer. So you assess the patient. That means you assess the baby. Test, do phototherapy and assess the baby. Now let's say this case 5. So 32-year-old female gave birth to a female baby. Okay. Baby was healthy at birth with normal sucking reflexes and activity. Everything is normal. After a couple of days, doctor recommended for bilirubin test of baby and told that the baby looked icterus. Okay, icterus means jaundice. The serum total bilirubin came out to be 12 mg per deciliter. Okay, direct is very less, means almost all are indirect, means unconjugated. Direct is normal here. So now doctor explained it as physiological jaundice, which happens because of rapid lysis of fetal hemoglobin and recommended phototherapy. What is the sequence of hemoglobin concentration present in this baby at the time of birth? So this is the same question I took from your MD1 and I kept here because it is relevant here also. So tell me, what is the sequence of hemoglobin at the time of birth? Which hemoglobin is?
So would it be B?
Is it B? Yes, it is B. So the baby will have highest fetal hemoglobin, then adult hemoglobin, then adult A2. So this is how it goes. Case 6, 44-year-old man presented to emergency department with abnormal abdominal pain. He has been experiencing this pain for the past few days. Abdominal pain for the last, it has progressively worsened. He has a past medical history of alcohol abuse. Remember it, abuse, never use. Alcohol is not used, it is abuse. So complicated by previous hospital admissions for acute pancreatitis. Okay. Physical examination is notable for right upper quadrant tenderness and hepatomegaly. Laboratory studies demonstrate a serum spotted AST level 350 unit per liter. And then ALT level is 152 unit per liter. Okay. So what is the diagnosis?
Hepatic.
It is it hepatic? Yes, hepatic. Which type of hepatic? What is the reason? Alcoholic liver disease. Alcoholic liver disease. What happens in alcoholic liver disease? This alcoholic liver disease, first what will happen? The first stage is fatty liver. Liver will have fat, but this is reversible condition. If person stops taking alcohol, the liver can reverse to normal. The second is severe condition, that if it is the patient does not stop, the liver will progress to cirrhosis. So fibrosis will happen in liver. All normal cells architecture could very beautiful are, you know, have you been taught the liver histology of liver?
Yes, sir.
Liver has, don't you know, this liver has very beautiful architecture.
Yes, sir.
Those whole architecture is destroyed because of fibrosis. So this is called cirrhosis, and this cirrhosis will have less viable hepatocyte, and if hepatocyte are low, enzyme in blood will also be low. In spite of liver, in spite of disease, there will be low enzyme level. Enzyme will not be 10 times. And I have also told you chronic has less than 10 times ALT and AST level. But the very important finding is the finding if you do the ratio. So if you do the ratio comes out to be more than 2, the Deritis ratio. Deritis ratio, if you find out that AST by ALT ratio, this comes to be more than 2. So this ratio, based on this ratio, you can be confident it is because of liver cirrhosis. The liver has progressed to cirrhosis, that is why enzyme level is low, but the ratio will be more than 2. So this is alcoholic liver disease, progressed towards cirrhosis. And you can do ultrasonography to find out if the patient has cirrhosis or not. You can easily find out that. Cirrhosis has the first stage liver swelling. Okay, liver swelling will be there in cirrhosis. Then liver, the liver will be small in size. What we call liver will be small. Swelling, then liver will be fibrous and a small type of liver will be there. So swelling liver, the patient came in the stage of swelling liver, and that is why hepatomegaly, abdominal pain, hepatomegaly you can see. So what are the investigation you would suggest? You can suggest other investigation. You know the investigation, color and consistency, because liver is damaged. So color will be what? Clay color, damaged. So clay colored stool will be there, and consistency again will have fatty stool. So the color and abnormal component, here also you will see bile salt in urine. Okay, because conjugation is not taking place in such condition, you can see bilirubin. You can do bilirubin test. It has not been shown here, done. So bilirubin, you can do the bilirubin test also here. So case 7. Okay, a 35-year-old male presented with itch on the limb and jaundice with no presentation. So patient told he was going through stress of oncoming postgraduate exam and did fasting for 1 day as religious fasting. On investigation, the total bilirubin came to be 2.4 mg per deciliter. Direct bilirubin was normal. The liver enzyme is normal also. So he does not have pallor or history of infection, immune disease. So what is the diagnosis?
Gilbert syndrome.
Gilbert syndrome. Very good. What are the investigations that suggest diagnosis?
Stress and fasting.
Yes, stress. Yes, you know. So that is good finding. Stress actually has effect in increasing bilirubin. Okay, what does stress do? Stress is actually increases hemoglobin HB synthesis, and then it will result into high bilirubin. So stress has high bilirubin level. So this is Gilbert syndrome. Investigation, you can do other investigation of liver enzyme, other tests. So it will all come normal. You can do hemoglobin, it will all come normal. So what would be the color and consistency? Normal consistency, normal color. No, there is no problem with urine also. So everything will be normal, only isolated hyper unconjugated bilirubinemia. No problem else otherwise. So you can see this condition. This is a very important condition. In So I have taken this case from here. You can approach this, you can find this case here also in 1994. So this day, because of immediate care in neonatology department, so patient gets immediate care. So that is why the patient does not progress towards the kernicterus. That happens, the abnormality that actually happens because of kernicterus, the patient is not exposed to that. It is the patient is treated before. So in 1994, apparently healthy white boy was born, 37 weeks gestation with 6 pounds, means 3 kg. The delivery was uncomplicated. Is 1 minute and 5 minute AGPR score. So AGPR score is done to check the baby, okay, consciousness, or if baby is doing well or not. So this scores was 8, means the baby was 9 actually. Normal range is 7 to 10. So baby was fine after birth. So it is 9 because the baby was fine. His mother's blood type was O positive. The newborn has A positive. Coombs test was also negative. No autoimmune destruction of hemoglobin. So on discharge at 20 hours, he was alert and nursing well. At 2-week follow-up appointment was scheduled at pediatric clinic. On day 9, the infant was taken to pediatric clinic with jaundice. The condition was thought to be result of breastfeeding. So breastfeeding also caused jaundice. Okay, so I'm not, because I don't want to confuse you. So just take it as information. You will study later also. But breastfeeding jaundice and feeding in this type of jaundice, breast milk jaundice and breastfeeding, 2 types of jaundice are there. Because of, if there is low breastfeeding also, there will be jaundice because of hybrid. Sometimes breastfeeding also cause jaundice. So we will study this next class in later. So that evening he was exhibited lethargy and was not nursing, had pumpkin orange skin coloration. So this baby has pumpkin, because they actually wrong misdiagnosed. The baby was misdiagnosed. On day 10, the parent noticed their physician about the infant's lethargy. Noticed their physician about the, notified their physician about infant lethargy and poor eating. Were given an appointment for following morning during a pediatric appointment on 11th day. The infant weight is also reduced because of dehydration, jaundice, and not feeding. So a tested serum sample revealed that elevated bilirubin, this 41 mg. So you cannot expect 41 mg per deciliter. Normal range is more than 72 is this normal range. You can see very high bilirubin. Despite treatment with phototherapy and 2 double volume exchange, so volume is exchanged completely in such patients. So if bilirubin is very high, phototherapy will also not work. This is the also treatment. You can see volume exchange. On day 11, he developed ethitosis. By now you know ethitosis, abnormal movement, purposeless abnormal movement because of basal ganglia problem, oral motor dysfunction requiring gastrostomy tube, and dental dysplasia. The diagnosis was made at age 6 months. So the diagnosis came out to be Crigler-Najjar syndrome. Okay, this is the Crigler-Najjar syndrome. What is the pathogenesis? You know, enzyme is deficient, and that causes high unconjugated bilirubin. High unconjugated bilirubin damages basal ganglia and other part of brain. And with time, the development of this brain part is delayed. And because of that, there will be ethitosis, abnormal movement, and other ataxia, those type of problem you will see in this patient. So let's revise this. So what jaundice is associated with anemia? Hemolytic jaundice. Which jaundice is associated with infection? Hepatic jaundice, you know this. Which jaundice is associated with biliary calculi, pancreatic carcinoma? Obstructive jaundice. Which jaundice is associated with fasting and stress? Gilbert syndrome. Which jaundice occurs occurs normally after birth? Neonatal jaundice, physiological jaundice. Which jaundice is associated with isolated conjugated hyperbilirubinemia? Dubin-Johansen rotor. And which jaundice is associated with isolated unconjugated hyperbilirubinemia? Gilbert Krigler-Najar syndrome, neonatal jaundice. So which jaundice is associated with kernicterus? So Krigler-Najar specialist 1, 2 is also 2 is also associated. So whole Krigler-Najar syndrome is associated with kernicterus. So molecular defect and associated bilirubinemia list. So you can see in kernicterus what. So these are you go through this. So Krigler-Najar syndrome 1 have more than 25 this, and you can see no UGT here, only 10% here, 30%. That is why the problem. So we have already done this. So these are the Gilbert syndrome, Krigler-Najar. We have already done. You can go yourself through this. So this is physiological neonatal jaundice. It starts in, you can remember, 1 week, then starts in 1 day, become high in the middle of 1 week, and actually become over after 2 weeks. So you can remember 1 day, 1 week, middle of 1 week become high, and then at 2 weeks it will be completely go away within 2 weeks. So you can go through yourself to this neonatal jaundice. So reason for physiological jaundice, you can see this is light therapy. What does light therapy converts? This light therapy converts the bilirubin, that is unconjugated insoluble form of bilirubin. This is, you can say, hydrogen bond formed on insoluble. ZZ form into E. You can remember Z. So Z, you can remember the formula Z. So it converts Z into EE form, ZE or EE form. So this is soluble. Hydrogen bond are broken, and that is how it is still unconjugated bilirubin, but it makes unconjugated soluble bilirubin because of light, blue light, 450 nanometer light. So this is bilirubin, this is kernicterus. You can study about the kernicterus yourself. You can study about the kernicterus, 3 phases. So these are the reasons. You can study yourself about kernicterus. Okay. So with this, we end.